Hi everyone, this is the last part of week 12 for financing healthcare, cost drivers, and cost containment. So we're going to look at cost containment. This one won't take very long, okay? In this one then, we're going to look at methods of controlling rising medical cost. And just a quick review, methods to control cost in medicine. What they're looking at is how can you use health information technology? How can we use the tools that we have to reduce and limit costs? So for one of those is use of the electronic health records and evidence-based methods. Yeah, the electronic health record's expensive, but it's also way more efficient than the standardized paper record. Clinical decision support systems, clinical practice guidelines, virtual technology, all of these are methods that will help reduce cost. So we'll go a little bit into those. Delivery models for reducing costs. One of the videos that you had in this course was a news report about an urgent care center closing down. But urgent care centers and retail clinics are one avenue that they use to help try and do that. Instead of overuse of the emergency room, if I've got something that needs to be taken care of, urgent care or retail clinics and malls are a way that you can go in at a reduced cost. They really have caught on quite a bit in that people know they're less expensive, and a lot of hospitals, especially in small communities, have published hours for urgent care there, or urgent care services. Physician extenders are also another part of reducing cost. If you have a shortage of physicians, a physician extender like a PA or a nurse practitioner is one method. And then the new one here is the patient-centered medical home. And that's where you get primary care or concierge medicine right at home. Technology, again, it's a driver. A lot of cost related with technology. Those improvements make a big difference. Another cost driver was utilization. We talked about in the previous slide, the increasing elderly. Increases cost in the instance of chronic disease. Administrative costs, all the different billing procedures and rules and processes that we have to do keep increasing cost. Our reimbursement methods, fee for service. You get paid what you build, it's going to encourage utilization, okay? And disparity within and among insurance plans also increase cost. Another driver is defensive medicine. Defensive medicine simply means when a physician does more than they need to get to where they want to be because one of the fear of malpractice and two, patient expectations. Tort reform, a defensive medicine. One of the things that they say is if you could get malpractice reform, it would help lower costs. But because of the fear of malpractice, you have a tendency to go over above what is needed. Patient preference, this is a big one. Patients who request for specific tests or medications. And that can be directly tied to consumer advertising. So a patient comes in and say, hey, I saw this on TV. I'd like to try this drug, or I'd like to try this test or this medication. That can help drive up cost. So how do you fix a broken system? Okay, you can limit available resources. You can ration healthcare. And then that takes a lot of work because there's exceptions to every rule. You can provide incentives to change utilization practice. So you can increase the cost to the patient, and if the cost increases to the patient, they're less likely to use it. You can also promote wellness and prevention programs to encourage wellness activities and prevention, and hopefully people stay healthier and don't need services. You become more efficient through health information technology and electronic evidence. You can do evidence-based medicine and clinical practice guidelines. Now, one thing, make sure you read the transcripts for these units because all of this is in greater detail in those transcripts to give you examples of this, okay? Health IT, so far at this point, it is our best chance to lower healthcare cost. And a part of that is the HITECH Act, which we discussed previously. But what they did was under HITECH, physicians or providers got extra reimbursement if they implemented meaningful use criteria in the electronic health record. In other words, meaningful use, certain standards of measure, certain things that you ask for on a physical exam, if that was incorporated. And part of that was to ensure that preventative care and wellness activities, one, were done, and two, just to get information to hopefully catch things earlier for treatment. Another thing that has been used, the best chance to lower cost, is facilities coordination of care, greater communication between different providers for coordination of care, so you reduce the duplication of efforts. And then supports for providers, clinical decision support. So on that one, for example, a person comes in and they present with varying symptoms. Clinical decision support will help say, it could be this, it could be that, it could be this. Clinical practice guidelines. What's the best practice for treatment of certain conditions, such as asthma, such as diabetes, such as heart disease? If you follow these guidelines, what's the chance of less future cost in maintaining that person? Shared information, always. And then the big thing is error avoidance and how to prevent medical errors. So evidence-based medicine, that's when you review published research for best practices and you have clinical practice guidelines. How do they improve care? They lower the cost, takes out that element of defensive medicine because you're doing the best practice guidelines and what's recommended. The critics of it say, is it cookbook medicine? Are you treating everybody the same? I know some of you may have remembered the television show House, and how House always was able to diagnose these exotic conditions they called that required care. And that was out of the realm of cookbook medicine. But a lot of our things that happen are routine and similar from person to person. Evaluating technology, that's another way that can help reduce cost. The medical home, this is a big push. That's where you get comprehensive medical care from a physician or director. You have a team, that care team, that will look at all aspects of a person's care that they need. And it's collective responsibility for getting that best care for that person. The medical home also enhanced access, same-day appointments. Coordinated care between your specialist and your hospitals and other organizations, the patients involved in that decision making and what's the best care they can do, and improves quality and safeties. Research has shown that the medical home can actually lower costs by 5.6%. Concierge medicine is direct primary care. The patient pays a fee or retainer monthly or annually. They get special service, enhanced access to medical care. However, you don't see a lot of that yet because there aren't a lot of models in our geographic reading. So make sure you read concierge medicine in your transcripts. This is an example of what the things can happen with that. Typical features of concierge: helps with wellness, nutrition, coordinating and medical care during travel, give workplace consultations, stop smoking programs, stress reduction counseling, mental health counseling, and some more benefits of that. Alternative delivery methods, urgent care. Again, we've talked about that. It's an alternative to the emergency room. Alternative care and urgent care, you can x-ray and lab, and they usually have extended hours. For example, from 5 to 8 p.m., those after work hours, and you pick up your child from daycare and they're sick, and you can go to urgent care. Retail clinics are non-traditional provider locations that might be in a mall, it might be in a freestanding facility near a shopping center. Usually they're staffed by nurse practitioners and physicians. Doctor of nursing practice. Okay, this is, again, that professions. When you get those nurse practitioners, they get postgraduate training, they can work independently from a physician. Lower costs than a physician, lower expenditures. They have limitations on what they can do. Tort reform is one way to lower cost. Frivolous lawsuits. You could legislate for you can't file a malpractice suit except for complications that would have been expected in a normal continuum of care. Or you can have tort reform in damage caps, so you can limit the amount that a person may receive in the event of a lawsuit. Or you could limit how much attorneys could get in the event of a lawsuit. Or you could put a limit on how much is awarded for pain and suffering. This is a pretty tough nut to crack, though, because if you think about tort reform, what industry is it going to impact? And that's going to be the legal profession. And you can visit about it, but it's got a long ways to go. So this one, summary in B, we have the highest healthcare expenses worldwide. Factors that increase that are demand and utilization, technology, pharmacy, and administration. We're impacted by EMTALA, which requires a hospital ED to provide care regardless of a person's ability to pay. We have an issue with the uninsured, even with Obamacare or the Affordable Care Act, they're still there. How we can improve it, we can become more efficient, and we can think of alternate delivery methods, and we can do tort reform. So this is a summary that you can look over. Next week, we're going to start week 13, and we are officially done with financing. We'll see you in week 13.